Hello and welcome to your periodic policy update for the Practice Group Network. My name is Alex Bardock and I'm the Director of Policy and Advocacy at AMDA, the Society for Post-Acute and Long-Term Care Medicine. As we reach the end of the year, I wanted to provide you with an overview of what we have done this year, and it's been quite a bit. Of course, this has been another busy year for practices practicing in the post-acute and long-term care environment. Another perhaps a somewhat difficult year trying to deal with still COVID outbreaks, in addition to now in the fall season with flu and RSV, and all of the different payment issues surrounding this practice area. But let's give you an overview of what we have actually accomplished, which has been quite a bit. And let's start with where we are with Medicare reimbursement for nursing facility services in particular. This is one of the biggest wins we've had in quite some time. As you may have heard from previous updates or some of the updates through AMDA, you know that we were able to secure millions of dollars in additional funding for Medicare for reimbursement for nursing facility services. As you may have heard, the nursing facility codes that everybody uses when they see patients in the nursing home were revalued. Those values have now been finalized in the CMS final rule that was issued earlier this year in November. And what that tells us is there are significant increases to majority of the nursing facility codes. And that translates to obviously millions of dollars in Medicare reimbursement. This was a lot of work over the last several years. And again, we want to thank those that filled out surveys that took some time to help us make a good presentation for CMS to value those codes. So again, this is one of the biggest increases we've had in quite some time. And as we know, payment for geriatricians, and particularly those practicing in a post-acute long-term care environment, continues to lag behind most other primary care and certainly other specialties of medicine. So we will continue to be vigilant on this issue. We will continue to try to secure additional reimbursement and to create more of a parity to ensure that we attract more qualified clinicians to the field. Remember that, of course, the codes in the nursing facility aren't just used by physicians, although they are included in the physician fee schedule. These codes, of course, are used by nurse practitioners and PAs and those that are able to bill. There were also, while we were on the topic, there were also significant changes to other codes for assisted living and home health. Those code sets were combined, and there are a number of changes that occurred there as well. We are aware that these changes could be overwhelming, and there's quite a bit to digest. And so what we have done is we've hosted one webinar by Dr. Chuck Crecilius and Dr. Bob Zorowitz, who went through a number of changes that have occurred that will be effective January 1. And I highly encourage all members of the Practice Group Network to view that webinar. The link to it is actually included on the AMDA homepage at paltc.org. And we will be sending out more information on that as well. So if you're not familiar with it, those changes have occurred. Again, I strongly urge you to visit our homepage to view that webinar, and we will have more. We want to ensure that we get all the questions answered. We want to make sure that practices going into the new 2023 year are aware of all the changes and are billing correctly, are being reimbursed appropriately because they're documenting and understand all the changes that have happened. So on that front, I think this has been one of the biggest years we've had in a long time, and in a very positive way. I will say that, sticking with the payment issue for a little bit, that, of course, most of you probably are aware that there's still a scheduled cut in that same final rule where we saw increases to the work values, what are called work relative value units for nursing facility services. We saw an overall decrease to physician payment, the overall Medicare payment to physicians. And that's due to a mechanism in Congress called budget neutrality, and that if CMS is paying out more dollars for these codes, they have to offset them elsewhere. In addition to the fact that there were increases included in last year's legislation to avert cuts and some potential penalties that you may face with the quality payment program. All in all, the cut is somewhere between 3.5% to 4.5%. As it's scheduled to take place on December 31st, 2022. We have been working with and aligned with many specialty societies on a plan to revamp the Medicare payment system. And in the short term, what that means is to fix the upcoming cut. So if we are able to do that, to avert the cut, and we are hopeful that Congress will do that, then nursing facility payment to nursing facility services will actually be even higher than what we were projecting. Speaking of that legislation to avert the cut, AMDA does have its grassroots activated. We ask all of you to visit our advocacy page and submit a letter to Congress asking them to tackle this issue. There have been a number of letters within Congress, members of Congress writing to leadership asking them to pass legislation in what's known as an end of the year package that funds the government to once again tackle this issue. You may have heard over the years since the mid-90s, essentially, that we have been dealing with this issue of a doc fix for a very long time. We thought we had it solved with the passage of MACRA that got rid of the sustainable growth rate, but here we are just a couple of years later fixing the same issue that we've dealt with for a long time. In any case, we ask you to get involved. We ask you to write a very quick letter. We have a template for you. You can send it to your members of Congress and ask them to take action. In other news, of course, we've also been continuously still dealing with COVID. And so AMDA has continued its activity, partnering with the CDC, talking with CMS, talking with the White House task force about issues related to COVID treatment, particularly around oral therapeutics. What can be done? Can they be used in different forms? For example, crushed. What about access to therapeutics? Are they appropriate? Can antigen tests still be used to, if there's an outbreak? So all of those issues we have been tackling with CMS and CDC, and increasingly with the White House task force. AMDA's president, Suzanne Gillespie, actually visited the White House for a roundtable on this issue, and we continue to have follow-up conversations. Needless to say, there's been a lot of attention paid to what is going on in nursing homes. Are things like Paxlovid being used? How are the vaccinations and the bivalent booster? Is that being administered? We are aware that the uptake rate in the communities are very, very low. What does that look like in the nursing home setting? Can we do more to ensure that we are vaccinating both staff and residents? And that's something that we are continuing to discuss. Speaking of COVID, of course, comes what we've been monitoring is where we stand with the public health emergency. As of today, we are still under the public health emergency. It is not, it was renewed back in October. There are rumors that it will be extended all the way until April. And essentially, the big news story around public health emergency is, of course, the waivers that were attached to it. And the big one among those is around telehealth. Telehealth is an area that over the last year we have been very active on. I know a very, very important issue for the practice group network. And that's something we are tackling. We are continuously discussing with Congress and CMS to allow more flexibility around telehealth for nursing facilities. CMS did finalize an extension of all the telehealth waivers for an additional 151 days past the end of the PHE, or public health emergency. So essentially, what in layman's terms, what that translates to is that it is very, very likely that for all of 2023, the same waivers that you have been used to over the last 2 years will continue to be in effect. That means that you can use telehealth to do all of these subsequent or medically necessary visits in the nursing home without any restrictions. To answer the question that's been popular over the last 6 months or so, the initial visit codes in the nursing home, so the initial comprehensive visits described by CPT codes 99304, 99303 through 99306, they do continue to appear on the telehealth list. However, because CMS lifted the waiver that allowed all physician mandated visits to be done via telehealth, although those codes continue to appear on the telehealth list per CMS rule, they are actually not allowed to be done via telehealth. So any physician mandated visit, those 30, 60, 90-day visits, including the initial comprehensive assessment, then in federal statute must be done within 30 days, has to be done in person. So that's something that's been a conversation within AMDA. We are our telehealth work group is working on some solutions around that and talking points as we continue to advocate, as I mentioned, with Congress and CMS on the issue. If you have, I'm sure everybody listening has experience with telehealth and the practice group network. If you have questions, if you have concerns, if you have ideas as to how it's going, what you're doing around telehealth, we would love to hear from you, as it is very, very helpful as we have these conversations to get experience from the field as to what you've been doing. How would, for example, an end to the public health emergency and that extension, how would that impact care in your facilities? And particularly we say that because one of the other issues that we have been very taking a lot of action on over the last year is the workforce issue. And that has to do, of course, with the direct care workforce from CNAs to LPNs, to all the way up to the medical director and the attending physician and the entire clinical team, and even supplemental services, dietary, cooks, you name it, that are in the nursing facility. We are aware, of course, of the crisis, the workforce or the care force crisis that exists in the nursing facility. It's something that we've been talking about for quite some time. We've provided testimony to Congress. We have talked about this issue with other stakeholders, and hopefully, we can find some solutions in the new year. We are also participating with the National Academies of Sciences that released a report on many different issues, but the highlight of it, of course, had to do around workforce. And they talked about the need for trained clinicians across the board, be that LPNs and CNAs to, again, NPs and physicians and medical directors. So we are continuing to work within the scope of the NASM report. We are participating on multiple committees that have been set up through that coalition called the Moving Forward Coalition, and we're very, very actively engaged in that work. That work, of course, will not be a short-term thing. It will continue into 2023 and possibly beyond. We view that as the same kind of report that back in 1981, when the Institute of Medicine issued its report, it led to the 1987 Nursing Home Reform Act, in the same way that we're hopeful that this sort of report can lead to substantive changes as to how nursing homes are done, as to how nursing homes are run, and care is provided within the next several years. So that again, a lot of work around all of those areas. And of course, on the medical director piece, we had a banner year moving forward our initiative around transparency of medical directors. I've been talking a lot on these sorts of updates in terms of our work to provide transparency as to the role and who the medical directors are, what are their training, what are their specialty, and so on and so forth. And we've talked to CMS over the years, we've talked to Congress over the years about this issue, and there are a couple of things that have really moved the needle forward on this issue. Number one, we were able to introduce federal legislation, bipartisan legislation in the House of Representatives that would mandate that every facility report its medical director to CMS, and CMS subsequently publish that information on the Care Compare website. And that would essentially allow you to see, to allow the public, allow the policymakers to see who the medical directors are, how many facilities do they serve, what is their training, and it would create a lot more transparency that we have been seeking on this issue. The American Medical Association also wrote a letter to CMS due to a resolution that AMDA brought to the AMA over the summer. And because of that, they wrote a letter to CMS asking that CMS indeed publish a public directory of all medical directors in the country. CMS, for its own part, issued a different request for information shortly after the bill was introduced. They issued a request for information on providing a directory of all Medicare providers in the country. We were very happy to see that they're actually discussing this, and we provided a response to that request for information. And we had many AMDA members submit letters to CMS as well in support of a medical director directory, as it would be included in that overall sort of provider directory. So again, a lot of conversations have gone on. We hope that we are still working to get more co-sponsors of the legislation. We urge all of you to write a letter to Congress, to your members of Congress, urging them to support the legislation, and in the Senate that they introduce the legislation. We are still looking for Senate champions and sponsors of the bill. And we're hopeful that we will get there, if not by the end of this year, that we will reintroduce the bill next year and get even more co-sponsors and introduce it in the Senate. But this is a big step for AMDA. We are very happy to have done this work. It is kudos to all of you that have supported us in all of what we've been doing. Our state chapters have also had a banner year. I mean, we have moved the needle forward on that issue as well. Number one, within AMDA, we have formed a formalized state-based advocacy subcommittee. And that came out of really a lot of work during the COVID time, during the height of COVID, where a lot of state leaders came together to discuss what they were doing on the various task forces within COVID. And when they quickly realized that there are many issues that they could impact in their states and their localities that go beyond COVID. And so we formalized that committee into a state-based advocacy subcommittee that's now worked on actually working on things like the Medicare medical director transparency on the state level. And that's actually been very, very successful. 2 states, one in California. California took the initiative actually and took it a step further. They passed legislation in California that required that all medical directors be certified by American Board of Post-Acute and Long-Term Care Medicine or its equivalent. As they were working on that piece of legislation, they also included the fact that now that they have to be certified, they have to know how to track that. And so they will include a registry of all medical directors in California. That has been a huge development because for the first time, a state is requiring that medical directors have formalized training and certification to serve in that role. We have had many medical directors from California reach out to AMDA, take and register for AMDA's core curriculum to get certified by our board, by the Board of Post-Acute and Long-Term Care Medicine. And we are hoping that more and more medical directors will take that route as the legislation is implemented. In North Dakota, for example, they were able to, and this was highlighted in our Caring for the Ages publication, they were able to go to their state health department and create a public registry or listing of all medical directors. In New York, additional activity is going on. In Maryland, additional conversations and activities going on. So all of that work is really, really moving forward. And I think this has been the year to highlight this again, where we've really not just talked about issues and not just talked about the need to be at the table talking about these issues, but what we've really done is now be at the table and move those issues from sort of a discussion to more of an implementation phase, which is simply incredible and a big step forward that we hope to build on in 2023. And all of you, of course, can help in that effort. You've already been very engaged in our practice group network. We hope that you stay engaged within that. We hope that you take advantage of all the resources and opportunities that we have. Of course, we will have once again a practice management track at our annual conference in March in Tampa, Florida. There will be sessions again on coding, on newest ACOs, including ACO REACH, on payment issues around physician driven payment model, on the quality payment program, and MIPS and MACRA, and all of the different issues that you deal with on a daily basis, things around health information technology, and reporting all those different things you have to report and data points that you have to report, whether on vaccine related issues or on quality measures around the quality payment program. All those things we will continue to discuss. And if you've been swimming in the sea of regulatory kind of some burden and other regulations that have kept coming down the pike with COVID and other things, please check out our annual conference. Please check out our track. We will be live. And so we hope to see many of you there. We hope to engage you in conversations. We hope to engage you in our discussions. We hope to engage you in even providing us with information and perhaps hosting discussion topics and webinars that are impacting your practices on a daily basis on the ground. This forum, as a reminder, was set up, the Practice Group Network was set up to really be a discussion amongst the various practice groups that are dealing with keeping a practice afloat in this environment in 2022 and beyond. So we encourage all of you to utilize the Practice Group Network Forum. We encourage you to utilize our various social media channels. Reach out to us directly, ask us if you want to get involved, and we certainly urge you to. Please let us know. We are looking for folks to serve on AMDA committees, such as the Program Committee, Education Committee, and our various subcommittees of our Policy Committee, Clinical Practice, whatever that may be. We urge all of you that are on the front lines of our practices to be involved and to stay engaged with us as we move all of this work forward. Again, I want to wish everybody a happy holidays and a happy new year. I think this has been an incredible year, as highlighted by the length of this update, usually a little bit shorter, but at the end of the year, a little bit longer. And we hope that we will have another year where we move many of these issues. And we hopefully next year, when we provide this update, we will talk about legislation that's passed, whether in states or in federal, regulations that help your practices rather than hinder them, and things that really move our post-acute and long-term care-based practices forward. Again, thank you all for staying engaged. Thank you all for what you do every day. Thank you for another great year of engagement and success within the Practice Group Network, and we will see you all next year. Thank you very much.